Fourscore and 7 years ago, yeah, whatever. Anna, can you hear me all right?
Yeah, I can.
Okay. So I understand you're going to have a nephew. Well, congratulations, Auntie Anna. Very good. It's 7 o'clock. It's time to start. Let's try and start on time. After looking at the slides, I didn't like the way it handled birth control. It just seemed very slipshod. So I threw together these two presentations. I sent them to you. We'll go through them and then move on to the next chapter. Did you all get the PowerPoint? So if you want to follow with me, that's fine. If you want to just listen, that's fine. If you want to write furiously, that's fine. It's up to you. Let's have a word of prayer. Our dear Lord, thank you for warmer weather. Thank you for everyone here. We pray for those not with us, those who are hurting, to comfort them, Lord. We pray now you help us get through what we need to get through efficiently. And Lord, please help us to view this professionally and without giggles. Amen. Because anytime you talk about reproduction, there's always, people get uncomfortable. And I guess it's okay that you get uncomfortable. That says you have a certain level of innocence. So that's a good thing, I guess. Okay, menopause. We'll do menopause first, then we'll do the birth control. When the ovaries are done with their follicles, you don't have the high levels of steroid hormones anymore. That is now going to cause a withdrawal. And this withdrawal that the body goes through is simply called menopause. The change of life, as it gets called, that's what my mother used to call it. So there's two main, oh, good gravy. Where is it? Where is it? Where is it? Better, but still not my favorite. So there's two main types of symptoms you see with menopause. One, of course, is the classic one that you're almost certainly all familiar with, the hot flashes. And these hot flashes can essentially cause a good deal of discomfort. They occur usually during the daytime. When they occur at night, you usually get night sweats. They may wake you up. They may disturb sleep. And nobody likes waking up and having their bed all soaked, but that's usually due to the hot flashes. The hot flashes are a result of the hypothalamus, which has a temperature sensor, getting fooled into thinking that it's too cold because of this withdrawal of estrogen. Estrogen plays a role in the signaling within that portion of the hypothalamus because of the withdrawal of the estrogen, now the temperature center says we're getting too cold because the signaling thing that's usually telling me it's warm is not there. So it beefs up the temperature in your body. That's what causes the flushing, the hot flashes, the sweating, so on and so forth. In some women, this is very pronounced. In others, it's just sort of, oh, I think I'm getting a little warm. So it's going to be very individual. The other are the genitourinary syndrome of menopause. That's the vulvovaginal atrophy. This requires estrogen for its continued elasticity and growth and repair and what have you. So that can cause dryness is definitely the big one there, but also vaginal burning, irritation. Do you guys know what dyspareunia is? That means pain during intercourse. Pain during intercourse. And then, because of the proximity in females between the urinary opening of the urethra and the birth canal, this can also cause dysuria because the wall of the pelvis can weaken, and that weakening essentially can cause reflux of fluids and things like that back into the bladder. So you can increase risk of urinary tract infections. Now, there are a whole host of ways to deal with this without hormone treatments. There are Kegel exercises that some doctors will recommend. There's definitely data that says that those help some people. There's also a variety of over-the-counter products for vaginal dryness and stuff like that. This essentially, the treatments we're going to talk about, the hormone treatments which do successfully treat both of these symptoms. These are if these other things don't work or if their results are unsatisfactory. They have a little bit, but I'm still miserable. Then you can go to these types of treatments. So with respect to the non-hormonal genital urinary syndrome treatments, you've got a whole host of moisturizers. And these are just a few of the brands I found. I basically went to the Walmart website and just looked at a bunch of them. And then there's lubricants, a go-go, tons of them. And according to Consumer Reports, these are kind of the ones that have the best evidence for efficacy. And these are the ones I put on there that seem to work the best. And again, the response you get from these varies from person to person. Some people, new lease on life. Other people, that stuff doesn't work. So if the thing I'm trying to get across is don't think hormones are the first resort. There are other things you can try before you go to hormones. Hormones should be when all the non-hormonal tricks fail. So if you go to hormonal treatments, so the treatments for the genitourinary syndrome, the hormone dosages are quite low, especially relative to what you would use for oral contraceptives. So estrogen is very effective. It comes in the form of vaginal inserts or a vaginal ring, for that matter. This particular ring, the S ring or E string or however you say it, that's in place essentially for 3 months. So it's something essentially you put in place and then forget about. You then have just inserts that you insert yourself, and you can see the dosages of these are quite low. And then you actually have creams and what have you. And these essentially do relieve the symptoms quite well. Now, estrogen has a downside. Remember, we talked about this last time. Estrogen is a mitogen. A mitogen. Clarissa, what's mitogen mean? Sarah, help her out. Mitogen. When you hear mitogen, think mitosis. Mitogens induce mitosis. So it's a mitogen for the endometrium. Because it's a mitogen for the endometrium, you're at increased risk for things like fibroids or uterine cancer. So it can increase your risk of those events. These are very low doses, but some women will be more sensitive to estrogen. So this is something that if a woman is on estrogen like this, that should always be a concern that's in place. And so she should have regular pap smears, she should have regular pelvic exams, things like that, to make sure that this is not an issue. And if there is a concern, you can get imaging done and what have you. Now, if you don't want to use an estrogen, you can use another product called ospemifene. This is a very interesting molecule. This is one of these SERMs. SERM stands for selective estrogen receptor modulator. Selective estrogen receptor modulator. But just a little word on how these work. So estrogen, remember, is a steroid. Since it's a steroid, if this is a cell, and that's its membrane, it doesn't bind to a receptor on the cell surface. It charges through the membrane because it is very hydrophobic. So it charges through the membrane, and then there is a estrogen receptor in the cytoplasm. It'll bind to that, and then the estrogen receptor estrogen complex will enter the nucleus and will elicit changes in gene expression. But here's the rub. There's several different types of estrogen receptor, and they tend to be expressed specifically in different types of tissues. So you have, for example, one estrogen receptor that's specific to bone. You have another that's pretty specific for the uterus, in particular the endometrium. And these are, ER alpha, ER beta, ER beta 2, ER beta, so on and so forth. There's different subtypes of these. So you can make drugs that will activate this one, but won't activate this one, or drugs that activate this one, but actually antagonize this one. Those drugs essentially that have differential activity on these different estrogen receptors are called selective estrogen receptor modulators. Selective estrogen receptor modulators. And we'll see a couple of these in our sojourn through anti-cancer drugs and other drugs like this. Is that clear? So this particular drug right here, ospemifene, is a selective estrogen receptor modulator. So it is a agonist What's an agonist? Binds a receptor and activates it. Antagonist binds a receptor and doesn't activate it. It gets in the way. So it's an agonist in the birth canal and in the endometrial epithelium. So it is pro-proliferation in this tissue here. However, it's an antagonist in the breast. Therefore, you don't have an increased risk of breast cancer with this drug. So this is used as an alternative to estrogen in women who are at higher risk for breast cancer. They may have breast cancer in their family history or something like that. Then you have another drug that is also a vaginal insert. This, by the way, is oral. This is taken as a tablet. This is dihydroepiandrosterone. Dihydroepiandrosterone, which is mercifully abbreviated DHEA, that is normally made in the adrenal cortex. And then when it enters cells, it can be converted to testosterone or to estrogen or something else. So this essentially, that's what this is. It's DHEA. And that is a vaginal insert. And that vaginal insert is essentially what you're applying in a case like that. So here's just kind of a lowdown of some of these different products. And so the only oral one on there is spemifene. And then all of these others essentially are vaginal inserts. That one up there is a ring, which is a vaginal insert, but that one you don't have to insert every day. These typically you do. And you'll notice that the dosages, again, they're quite small. 10 micrograms, 4 micrograms, 10 micrograms, blah, blah, blah. The ring gives you 7.5 micrograms per day, rather small dosages. So let's look at side effects. So with estrogens, again, they're low dose. So usually they're pretty well tolerated. You may have some application site reactions, that is, where you apply the cream or something like that may react, it may turn red or something like that. You may get vaginal bleeding and spotting. There may be changes to the breast. Those changes may be painful. These are not terribly common. Spemifene can cause hot flashes, vaginal discharge, muscle spasms. Muscle spasms is probably the most common of the side effects. Hyperhidrosis, what's that? Sweating, right, sweating. Venous thromboembolism, there's an increased risk of that. Endometrial thickening, polyps can also occur. And then with the progesterone, you get vaginal discharge, and then the pap smear can be abnormal. That goes away once you get off the drug. So that's not permanent. Mind you, these treatments are for post-menopausal women with an intact uterus and without risk factors. Those risk factors are obesity, hypertension, diabetes, and nulliparity. Nulliparity means you've never given birth. If you don't have an intact uterus, what's the point? You're taking this essentially for the uterus and the birth canal. It doesn't make a lot of sense essentially to take these. You're just increasing your risk for breast cancer if you take estrogen. Yeah. No, you take these if you've had a baby. Yeah. Progesterone can protect the uterus from the hyperplasia induced by estrogen. But at these low dosages, it's usually not necessary. However, if the woman is sensitive to it, then taking a progestogen might be advisable. Now, what about the vasomotor menopausal symptom and its treatment? In this case now, you're going to use more systemic treatments. So you're going to use higher dosages of estrogen. Because of that, you are going to need to combine that estrogen with a progestogen. Because endometrial hyperplasia occurs in more than 20% of the women who take an unopposed systemic estrogen. So these are higher dosages of estrogen, and they're going to put you at risk for hyperplasia of the endometrium and potentially endometrial cancer and also breast cancer. Also a conjugated estrogen with a SERM, and then also I put on here bioidentical hormones. Even though they're not regulated by the FDA, I still put them on there. So the estrogens come as tablets that you take orally. They also come in a transdermal form, a patch, and then of course a vaginal form. These tend to work pretty well too. There's lots of products that are available. They're available with and without a progestin. These will increase the risk, as you can see, for endometrial hyperplasia and therefore endometrial cancer and breast cancer. And of course, estrogens always increase the risk of venous thromboembolism, coronary artery disease, and stroke. Reports show that the transdermal estrogen seems to be less likely to cause thromboembolism than the other formulations. And because of that, some clinicians actually will prefer it. So combining these with either a progestin or the selective estrogen receptor modulator, vasodoxaphene, that's taken with a conjugated estrogen, and these will drop your risk for endometrial cancer. They will, however, increase the risk of breast cancer. So remember what we said last time about a self-exam? Learn how to do a self-exam, learn how to teach someone else to do a self-exam. If they find anything questionable, they should see their provider ASAP. Also increase the risk of thromboembolism and cardiovascular disease. Now, there is a micronized version of progesterone. It's used off-label. These micronized versions are given in these little tablets that release the progesterone slowly. They may be less likely to cause these effects. That really hasn't been studied, but some clinicians are kind of sold on it, and that's what they prescribe, or these micronized versions of the progesterone. Yeah.
So it says that more than 20% of that first line will increase risk for hyperplasia. So like oral birth control pills count as a systemic estrogen?
Yeah.
So that's true of the
Except those, as we'll see with birth control pills, they either come as just progesterone or as an estrogen progesterone combo. Typically not, because the progesterone concentrations are high enough to where they don't tend to do that. So this conjugated estrogen, selective estrogen receptor modulator, vasodoxaphene, its It is combined with a conjugated estrogen. This combo is called Duavy. So this is a drug, again, it will stimulate one, inhibit the other. So this one antagonizes the estrogen receptors in the breast and uterus. So this will decrease your risk for breast and uterine cancer, but it stimulates the estrogen receptors in the bone. So it's very good for women who are at risk for osteoporosis. Now, if you're shutting off estrogen in the breast and the uterus, you're going to get pretty severe vaginal atrophy. That's why it's given with a conjugated estrogen at low dose. And it's indicated in postmenopausal women who are at risk for osteoporosis. So, your job as a nurse, monitor bone density. Also, very often when you go to the dentist and the dentist takes x-rays, that is an indication of your bone health. If the patient starts getting loose teeth, there's evidence of recession of the gum and of the jaw. Make a note of dental health and also risks of fractures as well. This is one of your big responsibilities as a nurse. This is generally pretty well tolerated. Some people get nausea, diarrhea, abdominal pain, muscle spasms. Those are low percentage. Severe side effects, and these are rare, include your venous thromboembolisms, heart disease, congestive heart disease, breast and ovarian cancer, and then ischemic stroke. Those, again, are rare. If you go online, there are all kinds of people selling bioidentical hormones. So the complaint is that the conjugated estrogens are essentially isolated from the urine of mares. It's very abundant in the urine of mares. It's easily isolated, and it works quite well, and it's dirt cheap. That's essentially what Premarin is. So these essentially are made in a laboratory, and they're chemically identical to the estrogen, to estriol, essentially, that you make in your body. These products are not regulated by the FDA, which means they're not tested in FDA-approved laboratories. There's absolutely no evidence that these are better than synthetic hormones. And very often the dosages are semi-well worked out, but not rigorously tested. So if people really want to go with these, I hate to say this, but very often people who push these are chiropractors. My rule of thumb about chiropractors is chiropractors are experts in the spine, in the back. When they get away from that and they start selling, mega doses of vitamins and this crap, they're now moved from chiropractic to quackery. And if a chiropractor tries to sell you stuff like that, turn around and go back out the door because they're a quack. It's just that simple. They're not trained to prescribe this stuff, nor are they licensed to do so. And very often, they're getting a kickback from the company for doing this. So frankly, I think you'd call that in our profession unethical. I think you'd call that conflict of interest. Yes? Let's say Tori over here is a nurse practitioner, and she gets somebody who comes in, and she's a 55-year-old woman, and she has menopause, and she was offered a trip to Belize by the company that sells these, and she prescribes those to this lady. What has Tori just told that woman? She told that woman that you're for sale. Do you want to go to a healthcare professional who's for sale? Who doesn't have their patient's interest first and foremost instead of their own comfort? No, I think that the answer is HE double hockey sticks, no. So when Jesus said, when I was in prison, you came to me, when I was sick, you healed me, you were doing that in spite of your own comfort, not to please yourself, essentially. So just don't go there. Just don't go there, okay? Non-hormone treatments. Again, you see a lot of these on the web, and you see them sold in health food stores and by naturopaths and, unfortunately, chiropractors. Don't get me wrong, there are plenty of chiropractors who do a very good job. Bob Kenty over here is a great guy. He won't sell you any of that rubbish. But there are others I've been to and just, yeah. All right, so this is not quackery. This is actually FDA approved. This is a low dose version of the antidepressant paroxetine, and this will actually relieve hot flashes. So it'll cause headaches, lethargy, nausea, and vomiting. And it's an inhibitor of cytochrome P450-2D6. Do not use it with tamoxifen. Tamoxifen is a prodrug, and it needs to be activated by 2D6. If you use this drug with tamoxifen, you'll have treatment failure with the tamoxifen, or any other drug that's metabolized by cytochrome P450-2D6. So here is the sorts of things you see on the web: phytoestrogens, black cohosh, evening primrose oil, ginseng, donghai, wild yam, red clover, acupuncture. When you look at the studies for these, and they have been studied to some extent, one, the studies tend to be poor quality and small. Two, the results are all over from here to Indianapolis in terms of their efficacy. And three, the evidence for their efficacy is poor, very, very poor. The only one that really seems to show any efficacy to any extent really it's soy. Soy foods and soy extracts, they might cause a modest reduction in hot flashes and vaginal dryness. Black cohosh is linked to hepatic toxicity. My sister swore by black cohosh when she went through the change. I kept trying to break it to her that there's not a lot of evidence that it works. She says, "Oh, shut up, it works for me." Anyway, the evidence for these is poor. And if people are using a lot of these and they're using estrogens, the effects can be additive. So your job, because you accept it, and if you're going to be a nurse, you better, is to make sure your patient discloses all this other stuff that they're on. That's menopause. Are there any questions about any or all of that? No? And now for something completely different. Contraception. You guys are going to deal with this a lot as nurses. So this is a field you guys should be pretty familiar with. What you do, women's health, family practice, peds, because peds, you deal with adolescents. You'll be dealing with this. Internal medicine, even surgery. You have to ask about contraceptive methods. You have to get pregnancy tests, so on and so forth. You'll be dealing with this. You will. That's just all there is to it. So when it comes to methods of contraception, there's kind of, oh, that's terrible. That is hard for you to see as it is for me to see. Is that better? Okay. I was trying to do kind of the dark side of, So there's tier one. Tier one's the most effective. Tier one, you get essentially one pregnancy per 100 females, and that's a high-end estimate, essentially. Tier two, slightly less effective, 4 to 7 pregnancies per 100 females, and that's very high end. Tier 3 would be least effective, 13 pregnancies per 100 females. And Tier 3 essentially are all non-hormonal strategies, is where at least most of Tier 1 and 2, well, all of Tier 2 are hormonal, most of Tier 1 are hormonal. So let's go over the Tier 1 methods first. So these are the long-acting, reversible contraceptive methods. The long-acting, irreversible ones would be things like tubal ligation and vasectomies, which I'm not going to cover because that's not pharmacological, but just keep in mind that's part of the armamentarium of contraceptive methods. These are reversible. So they include IUDs, contraceptive implants, and then vasectomies, and then bilateral tubal ligations. Those are mostly reversible, irreversible, because there are surgical procedures whereby you can reverse them. Although with vasectomies, if you've had a vasectomy for a while, now you have antibodies against sperm, and that makes the reversibility suspect, very suspect. If you've had it only a short time, it's potentially reversible. Whereas with tubal ligation, there's more chance for reversibility. Okay, IUDs, very highly effective. Once they're inserted, essentially you can forget about them. You don't need to take a pill every day. Don't need to worry about it. It's in, it'll do its job. No worries, essentially. Once you take them out, fertility is restored. And it's restored relatively quickly. The risk of cervical cancer is actually lower in women who use an IUD. Although those that use the synthetic progesterone, levonorgestrel, they can reduce dysmenorrhea in women prone to dysmenorrhea. So IUDs can be hormonal or non-hormonal. The non-hormonal IUDs are made of copper. Copper is released slowly. IUDs copper is toxic to sperm. It's toxic to sperm. So copper IUDs completely avoid estrogen or progesterone. And you can literally have a copper IUD put in and it'll last 10 years. In fact, the longest I think a woman's had it in is 30 years. Now it works for at least 20. After 20, I'm not sure anyone's tested it, but for 20 years it will work. Then you have hormonal IUDs. They release low dose levonorgestrel. Now irregular bleeding is common with progesterone-based methods, so these can cause some irregular bleeding. By irregular bleeding, you're bleeding at a time outside your menstrual period, that period of time of menstruation. So levonorgestrel is going to prevent pregnancy by inhibiting the release of luteinizing hormone by the anterior lobe of the pituitary. You don't ovulate, and then you also have thickened cervical mucus that prevents the sperm from penetrating the cervical plug. And then it thins the endometrial lining so that if fertilization should occur, you don't get implantation usually. It can lessen the pain and blood loss during menstruation. It's useful for women who have abnormal menstrual cycles or for those with endometriosis. These are the 5 different, good night, that's the size of a Post-it stamp. That got small. Is that a little bit bigger? No, not really. Well, here, I'll read it to you. How's that? So the 5 of them, first of all, there's Paragard. Paragard, it's FDA approved. That one's copper. It's FDA approved for 10 years, but it's been shown to be effective for up to 20. So that's the copper one, Paragard. Then you have, all the rest of them are hormonal. So Mirena. Mirena is the other one. That releases levonorgestrel. All of these release levonorgestrel. That's the progestin that's used in the hormonal ones. That one's good for 7 years. And the dosages, you guys don't need to know that. Just the thing I want you to see is that they start out releasing this much, and then as they stay inside, they start to decrease the amount that they release. So by the time they're removed, they're releasing less and less and less of the levonorgestrel. Then there's Liletta. That's used for 5 years. Then there is Skyla. Skyla is a very small IUD. So it's good for small women with small uteruses. That's good for 3 years. And then there's Kylena. Kylena is also small, like Skyla, but Kylena is used for 5 years. So here are the adverse effects of IUDs. There are cases of uterine perforation. Those are rare. Those are rare. If you read on the web, it may sound as though that's really common with IUDs. It isn't. That is crystal clear from the literature. During the first week, bleeding and cramping are pretty common. So that's a downside. Irregular heavy bleeding and cramping may occur first 3 to 6 months after the placement of the copper IUD. You'll get irregular or light bleeding during the first 3 to 6 months following the insertion of the hormonal IUDs. That will decrease with continued use. IUDs do not increase the risks of STIs or pelvic inflammatory disease. It was believed at one time that they did. It's now very clear that they don't. So old books may say that they do, but they pretty clearly don't. The hormone-releasing IUDs may increase the risk of ovarian cysts. These are asymptomatic. Many will resolve spontaneously, some don't. That's something people with IUDs then are going to need to be checked for. The way you would detect those is usually with imaging. And you will probably want to recommend to your patient that they get imaging, and then maybe you want to do just a quick little pelvic exam, abdominal exam, palpate the abdomen, and see if you feel a hard spot, and so on and so forth. IUDs sometimes can just come out. And if they just come out, then you can't just grab them and put them back in because they need to be inserted by a clinician. The systemic levonorgestrel is less with IUDs than it is with oral contraceptives. Also, levonorgestrel can cause some acne. If you have acne, it can make it worse. Other than that, these things are pretty well tolerated. So don't use copper IUDs if somebody has Wilson's disease. Wilson's disease is a disease that prevents you from properly storing and disposing of copper. So your copper levels are very, very high in your body. Also, if anyone has a copper allergy, don't use a copper IUD. Don't use a hormonal IUD in people with liver disease because the liver metabolizes the levonorgestrel. Don't use it with breast cancer because it'll make the breast cancer worse. Other than that, you can use them. So the IUD should be inserted by a clinician. You can't just buy it off the shelf, put it in yourself. Clinician has to insert it. There's a string with it. The string will protrude into the upper border of the birth canal. That can be used essentially as a marker to tell you if the IUD is still in place. The hormonal IUD should be inserted between days 1 and 5 of the menstrual cycle. If you do that, it will have an immediate effect. If you insert it after the 5th day of the menstrual cycle, then use backup contraception, whatever you want to use, condoms, sponges, diaphragms, whatever, spermicides, for 7 days. Then after 7 days, the IUD will kick in. Coppers, you can put them in any time. In fact, copper IUDs can even be used for emergency contraception if you use them within 5 days of unprotected intercourse. Questions about IUDs? Have you guys seen an IUD? Any of you? They're kind of, well, when they're, before they're inserted, they're like a, huh? Yeah, except smaller. And then when it's put in, it opens up and it's kind of like a T. And it just sits in the uterus, just like a T, and releasing whatever it releases, copper, levonorgestrel, and what have you.
How does that work against
the lining sheds around it essentially. Yeah. Okay, the next tier one are subdermal implants. Subdermal implants. And the product here is Nexplaxin. And this is literally what it looks like. It's a little rod, and this little rod contains the synthetic progestin etonogestrel. And so this rod is placed under the skin of the non-dominant upper arm, usually on the inside. And it will release the etonogestrel. Initially, you get this amount, then it decreases at the 3rd year. Once placed, you get this long-term protection against pregnancy, and you don't require any other adherence other than an office visit for replacement after 4 years. So this will give you 4 years of birth control. You don't have to take pills. You don't have to do anything else. Boom, that's it. Bleeding irregularities are common with this. But that essentially is what it looks like. Some people have reported that the insertion sometimes can impinge upon nerves. And some people have reported some pinching pain occasionally. That can be remedied usually. Also, there are alternative places to implant it. You can implant it in the back, usually along the back here like that, or other places like that. It's put in using a device like that. It goes in very quickly and relatively painlessly. So it's put in, again, by a clinician under local anesthesia. You insert it 1 to 5 days during the 1 to 5 days of the menstrual cycle for immediate effect. If after that, you use backup contraception, then for 7 days, and then it kicks in. And that's the Nexplaxin. Nexplaxin. Sorry? It gets placed usually on the inside of the non-dominant arm. the upper part of the inside of the upper part of the non-dominant arm. It releases the synthetic progesterone, etonogestrel. There used to be these little inserts you could get called Norplant. Norplant's not made anymore. Now it's essentially, yeah, that was Norplant. And Norplant's not used anymore, not marketed anymore. You may have unpredictable menstrual bleeding, shorter or longer periods than before, no bleeding at all, or irregular periods. So your periods may get a little wonky. That can be, I'm sure, extremely inconvenient. Others are pretty common for progesterones: headaches, bloating, weight gain, acne, tenderness of the breast. Once you remove the rod, women ovulate within a month. Same thing with the IUDs. Once the IUDs are taken out, you ovulate within a month. With the copper ones, you ovulate anyway. So if you want another rod, you can just have another rod put in. So there you are. Questions about Nexplanon? Yes, Sydney.
I've heard horrible things about that. Is that like, what's your opinion?
My opinion is if it's put in properly, that's usually the biggest complaint is when it's put in, people feel like they have this welt on their skin. The thing is, the rod is really small. And it shouldn't do that. It's usually not put in properly. When it's put in, if it's put in properly, then it's usually not an issue. Some women will have more trouble with it than others. But if it is really causing you trouble, you can have it taken out and then go on either oral contraceptives or something else. So the reports that I read about it were research not published by the manufacturer. You have to watch out for stuff like that. They have these glowing reports. And the reports are pretty positive on the average. People who hate it really hate it. But the ones who love it really love it because eventually get it put in and then you don't have to worry about it. It's out of sight, out of mind, and not a worry. All right, this is a good time to take a break. Once again, my wife struck and made apple crisp for you guys. And since we have people not here, that means more for you all. So please come and have some. I haven't had any yet, but I haven't had dinner either for that matter. Well, then come down and have some. So let's go ahead and so we'll take a break and enjoy. Contaminated. Sarah's field is on the floor. No, I'll do it in the middle. Okay, I'll like on this side. I'm definitely here. I'm here. 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 Here.
Okay.
There we go. Look at that view. Come here, Shay. Thank you.
Or I want that one right, the next one. Yeah.
Oh, cute, beautiful. Oh, you are so beautiful.
Yeah, just maybe.
Anyone else? I'm gonna want more. I'm gonna want more. Me too. Babe. Oh, baby. Oh, you're not food. I don't know. What is it? I just heard a lot of people are against it. Well, they're going to I didn't. I don't know. And oh, it's not cold in the water. Like,
What it means.
I don't know where that is. What is the date of our time? I have a calendar right here. I love my door.
No, nothing. Well, guys, I hate to break it to you, but we need to get started again. So, yeah, I'm sure. But if you want some more, see, Tori knows it's good.
Oh, we didn't say it wasn't good. Trust me. I think it's good. It's,
So feel free to have some more.
what's your favorite thing that?
Her apple pie is really good.
See, this is kind of close to apple pie, so I would believe it.
She likes making that better than apple pie because she hates making crust. So she buys the rollout dough and she does that essentially, and that works just fine. So, all right, tier 2 methods. These include the oral contraceptives. So there's 2 main types of oral contraceptives. There is a progesterone only, and then there's a combination of progesterone and estrogen. So the progesterone only products are called mini pills. Mini pills. So these are going to, excuse me, inhibit the hypothalamic secretion of gonadotropin releasing hormone, and also prevent the release of the pituitary gonadotropins. So ovarian follicles fail to develop, ovulation fails to occur, and then you have these other additional effects that are also contraceptive in nature. They thin the endometrial lining, preventing implantation, thicken the cervical mucus, impeding the passage of sperm through the cervix and the cervical plug. Most of your mini pills are norethindrone. Most of them are. There's now a new product with drospirenone. It's quite new, but most of your mini pills are norethindrone. So Slind, this is quite new. It was approved end of last year. This is drospirenone. This particular drug doesn't have the androgenic effects that other progestins have. So it doesn't exacerbate acne. In fact, many women say on drospirenone, say that it improves it. Side effects are very similar. Oh, sorry, I turned those lights on so we can see what we're eating. Side effects: headache, nausea, regular bleeding, breast tenderness or pain, weight gain, dysmenorrhea, that is bleeding, at times outside the menstrual cycle, decreased libido, that means your sex drive is decreased. Drospirenone has an anti-mineralocorticoid aspect to it, so it can cause hyperkalemia. Hyperglycemia has also been reported, as has amenorrhea, that is, no periods at all. If you use drospirenone with other drugs that increase serum potassium levels, that will increase the risk of hyperkalemia even more. So, upshot, if someone's on a drospirenone containing contraceptive, they should have a blood test for potassium levels regularly. Many pills can mitigate the effects of menstrual cycles, excuse me, in people who simply have menstrual cycles that are not well regulated. So if you have Heavy bleeding or pain because of either endometriosis or ovarian cysts. Many pills can really regulate that and make the patient feel a lot better. They can also really help people who have polycystic ovarian syndrome. And they also can be used as hormone replacement therapy in people with Turner syndrome, who have hypogonadism, or individuals with premature ovarian failure. So they have other non-contraceptive uses and non-contraceptive benefits. Many pills are extremely good for two groups of people. If you have a woman who's just given birth and she wants to get back on birth control, but she wants to breastfeed, many pills are perfect because the progestin is not excreted into the breast milk, but estrogen is. And you can take these right after you give birth. That's the beauty of them. They're also good for women who are older or women who smoke, because smoking raises the risk of venous thromboembolism in women who take estrogen. Many pills will not raise that risk quite so much. Now, the big downside of many pills is that you must take them at the same time every day. If you don't, their effectiveness goes down. In fact, if you vary how much you take them during the day by 3 hours, that's enough for them to fail. So when prescribing a mini pill to someone, if you're prescribing them to someone who is, forgive the expression, kind of scatterbrained and tends to forget a lot, and they really won't take the pill. Now, granted, we have cell phones nowadays we can set to remind us, but they're the type of person, well, they'll do that, but they lose their phone. Maybe a mini pill is not the best treatment for them, because this type of adherence is really important. So you get decreased menstrual cramps and pain, decreased menstrual blood loss. These are some of the advantages to the mini pill. Adverse effects, again, this is like a broken record. With progestins, this is what it is. Irregular bleeding or spotting, headaches, mood swings, breast tenderness, increased risk of ovarian cyst. But you get off a mini pill, within one cycle, your fertility returns. Contraindications, again, same song, second verse. Liver disease, active breast cancers, they do have a lot of drug-drug interactions. So they interact with several groups of antibiotics. They interact with several different types of anti-seizure meds. They interact with dapsone and griseofulvin, and also the herbal supplement, St. John's wort. So there are multiple DDIs. Do make sure that if you have a woman of reproductive age, you make sure, if you're working, say, at urgent care or something like that, make sure you get an idea of the medication she's on. Because some of that medication, if she's on a mini pill and you're going to prescribe a macrolide, that's going to interfere with her mini pill. You may want to recommend that she have backup contraception during that time. Any questions about the mini pills? They are not as effective as the combination pills. That's very clear. And now we go to the combination pills. These are the, again, excuse the potentially crass language, but these are the workhorses of contraception in medicine. So these contain ethinyl, estradiol, that is the estrogen. Virtually every single one of them contains. Then the progestin they contain varies. There's one exception, Natasia has estrogen valerate. That's the only one that's different. So of these progestins, norethindrone and levonorgestrel, they are synthetically derived from testosterone. So they have some androgenic activity. They're going to alter your lipid profiles. They're going to lower your HDL, and they're probably going to raise your triglycerides. Drospirenone, dasogestrel, and dienogest, they have anti-androgenic properties, and they will usually improve acne. In fact, drospirenone improves the symptoms of premenstrual dysphoric disorder, which is formerly called premenstrual syndrome. Premenstrual dysphoric disorder, also hirsutism, that's the growth of hair in places where you don't want it, like on your face, and acne. Hirsutism is seen in people with polycystic ovary disease or polycystic ovary syndrome. Drospirenone can mitigate that. So you see it in red, that means you should pay close attention to it. Your lipid profile should be checked regularly for all patients on oral contraceptive pills. That's what OCP means. They have lots of choices when it comes to oral contraceptive pills. Monophasic, biphasic, triphasic, fourphasic, extended cycle, or continuous. Well, what the heck does all that mean? So monophasic means you have one dose of estrogen and progesterone throughout the time you take the pills. Doesn't change. It's one phase monophasic. And you can see you have lots of different combos of these. The estrogen is always the same, ethinyl, estradiol, and then various types, levonorgestrel, dasogestrel, norgestrel, drospirenone, norgestimate, blah, 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 blah. Lots of different products, so on and so forth. Some of them come with folate. Some of them actually come with iron in them as well. And what have you, it's just, yeah, all over the place. Many of these are so-called 21/7 formulations. That means you get 21 days of medication, and then the last 7 pills are placebos, because that's the week during which you'll be menstruating. You don't need to take any hormone at that time. Others are on the 24/4 pattern. 24/4 means you get 24 days of pills with hormone, 4 days of placebo. That will tend to give you lighter menstrual cycles. If you're someone who has heavier menstrual cycles, you're tired of those, you want something lighter, the 24/4 can cause less amounts of bleeding, shorter periods, and a new lease on life for some people. Biphasic. Biphasic is going to vary the concentration of the progestin during the time that you take the pills. So it's biphasic. There's 2 phases, 2 concentrations of the medication. And so the progestin dose gets increased halfway through the cycle, biphasic. And there's several types of these and the product names and blah, 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 blah. You get the point. There's lots of choices. Triphasic. Now, there's 3 different concentrations of the progestin. Concentration of the estrogen, again, stays the same. So that's why some of these, you look at them, they're called 777. That's a tip-off, it's a triphasic. And then the fourphasic, there's 4 different doses of the progestin during this 28-day cycle. And I know you're dying to ask me, is there any difference in efficacy between these? The answer has been, the question has been studied in some detail. The answer is a resounding no. No. Plus, with these multiphasic types of preparations, you have to be very careful about which pill you take when. That's why the monophasics are by far the most popular. Because they're just one type of pill. You don't have to worry about it. Then you have a 91-day arrangement where you have 84 days of medication, and then you have the 7 days of placebo. So you get 7 days of placebo every 3 months. So you end up having 4 periods a year. That is if you want fewer periods. Some people use the 91-day arrangements. Then you have continuous birth controls. These don't have any placebos. You just take pills that have hormone constantly. These are usually monophasic. You don't have periods. You don't have periods at all. And those are some of the products that are continuous. Yes?
Do any of these like deplete certain vitamins? Like I started taking them for a long time.
That's why some of these are supplemented with folate.
Oh,
Yeah, and also some of the placebos will have iron in them. Since you're going to bleed during that time, it gives you iron to replace that, which is kind of ingenious. Yeah, folate is the biggie. And then if you want to get pregnant, you need adequate folate anyway. And if you've been on the birth control pills and then you try to get pregnant, your folate's low. That's why if you do go get off these, you should get on the pregnancy vitamins ASAP, essentially. So, patient comes in, I like a prescription of birth control pills. First thing you do, pregnancy test. Pregnancy test must be negative. Now, the estrogen in the pill is lower than the estrogen the placenta is going to make. So the pill will not hurt the baby, but they're taking it to prevent getting pregnant. It's kind of a moot point. So that's why you don't want to waste their time. That's why you take pregnancy test. It must be negative, or they don't get the oral contraceptives. Secondly, you ask this question, when was the first day of your last menstrual period? If it was less than 7 days ago, you can start the pills immediately, use backup for 7 days, and then you're good. If it was more than 7 days, was there an episode of unprotected sex? Yes, you have to ask people personal questions. That's part of being a nurse. If the answer is no, cool. Then you start the oral contraceptives, use backup for 7 days. A lot of people think they get the pills, they're protected right away. They're not. They're not. There's that 7-day window. You have to use backup contraceptive. That's an important education piece. You must give your patients. If the last episode of unprotected sex was less than 5 days ago, then maybe emergency contraception should be considered. If that's the case, the pills can be started the same day. And if the last episode of unprotected sex was more than 5 days ago, and the patient can't remember, emergency contraception is not effective because it has to be within 5 days. The pills can be started the same day, then you retest for pregnancy 2 weeks later to confirm she's not pregnant. The pills in that case won't hurt the baby. To start them, there's 3 strategies. Quick start, Sunday start, first day start. quick start is you get the pills, you start it. Use backup contraception for 7 days. Bob's your uncle, you're good to go. Then there's a Sunday start. You start the Sunday after your period begins. Then use backup contraception for 7 days. Bob's your uncle, there you are. Then there's the first day start. You take the pills on the first day of menstruation. Now no backup contraception is required. So in that case, you're covered, but all the others, you need to use backup contraception. Do you guys see how much patient education is involved with this? There's so much more than just giving your patient the pills. And the doctor won't necessarily explain this to her, you do. And so you have to understand it. Okay, this is just the difference between extended use and continuous use. The extended use is the 91 days, 84 days on, 7 days off. That's extended use. You'll have 4 periods a year. Continuous use, you won't have any periods. Some combinations are 21/7, others are 24/7, the 24/4. 24/4 gives you lighter periods, less bleeding, shorter periods, so on and so forth. Now, if you elect the extended or continuous use, there's some benefits for people who have endometriosis, people who have some sort of hyperandrogenism because of PCO or something like that, people with the premenstrual dysphoric disorder, people with premature ovarian failure, or people in menopause. These are the advantages essentially of using either the extended use or the continuous use format. All right, what about the side effects? So headache, nausea, bloating, breast tenderness, and breast enlargement. Breast tenderness and breast enlargement. If your product contains less ethinyl estradiol than 20 micrograms, you're going to get breakthrough bleeding and spotting usually. In the initial cycles of the extended or continuous regimens, you usually also get breakthrough bleeding and spotting as well. And then again, if your product contains drospirenone, it can cause hyperkalemia. If you have higher doses of the ethinyl estradiol, that is equal to or greater than 50 micrograms, you have increased risk for heart attack and stroke, particularly in those who smoke or have uncontrolled hypertension. If you're on the combination pills, your risk of a blood clot is 2 to 3 times higher than those not on them. This risk is even higher in those who smoke and in those over 40 years of age, or those who are obese, or those who have some sort of inherited thrombophilia or history of venous thromboembolism. And these progestins, desogestrel, drospirenone, they can produce an even higher risk of venous thromboembolism than levonorgestrel. Breast cancer risk. Some papers say yes, others say no. I'm going to just put that one in the toss-up category. For a long time, it was kind of gospel that these products increased your risk of breast cancer. That's not so certain now. So I think it's probably clear it increases breast cancer risk in some people, but just to be safe, teach your patient how to do a self-examination and then have them do it for you just like before. So that's the same as before, essentially. Mood effects, there is an increase in depression risk. Definitely an increase in depression risk. Antibiotics don't interact with combination birth control pills. Rifampin does, but all the others don't. You see these stories on the web constantly about how people got pregnant because they got sick and they took their antibiotics and it messed with their birth control and now they're pregnant and oh, that darn amoxicillin. No, nope, 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 nope. Really, it's rifampin and St. John's wort. Those are the two you need to worry about. Also, other drugs that increase cytochrome 3,450, 3A4, because 3A4 is the enzyme that metabolizes estrogen. Am I going too fast? No? Keep trucking? I'll keep trucking. Patches. So there's this product here, Xulane. This delivers 35 micrograms of the estrogen, and then it uses the norelgestromin. This is effective, but it's less effective in obese women. So this is not recommended in obese women. Adverse effects, what have you, are virtually the same as for the oral contraceptives. The patch should be applied to the lower abdomen, the back, the outer upper arm, or the buttock. You apply the patch for a week, and then take it off, put another one on, and do that for 3 weeks. Then you go patchless for a week, so that's your placebo week, and then you go with another patch after that. There's a new product, very new, in fact. This is called Twirla. This is the package it comes in. This is a circular patch. You can see the Xulane is kind of a square patch. This is circular. This delivers less estrogen than Xulane, so it's safer also. This particular patch, once you use it for 3 weeks, you take it off and then you can put the same patch on. So that one patch will actually last you for several months, which is kind of cool. You don't have to keep buying patches. Twirla. Vaginal rings. Vaginal rings. So these also deliver a dose of a progestin and a estrogen. You place them intravaginally and you leave them there for 3 weeks, and then you're a week ring free. And then a new ring is then used for another 4-week cycle. And if you remove it for more than 3 hours, you should use backup contraception. And that's essentially what it looks like there. So the two products are the Nuva ring and then this other product, Eluring. Those are the kind of mainstay products. These have efficacies that are very similar to the oral combination contraceptives, although your users will report less acne, less irritability, and less depression. The downsides of these is you have to insert them, which some women find distasteful. There's a new ring product, was approved middle of last year, called Anavera. And this can be reinserted. This is kind of like the Twirla. This one, you can actually reinsert the same ring. Take it out and then you reinsert the same one. So it's kind of the only ring you'll ever need sort of thing. So these do provide good control. Shane, do you have a question? These provide good control, and you take them out and you don't use them, you return to fertility rapidly. Most people who have discontinued them will say they either get weird vaginal discharges, headaches, or the device just feels funny. The majority of women who use rings don't feel them, but some do. They also can slip. That's one of the other features of the ring. Okay. Estrogen and progestin. Yeah. 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 No, the cervix kind of makes a little cone on the inside of the birth canal, and the ring essentially goes up in that little space where the cone is. So no one will feel it during intercourse. Problem is that it can get dislodged. It can slip. And I think we had a soccer player who used it. And she said whenever she played soccer, it came out, which must have been just a drag. That others say they don't have a problem with it. Others say they can never get in. The insert that comes with it shows you how to put it in. There's pictures and everything. Some women put it in, no issue. Others like, oh, I can't. So it works really well for some women. Others, it's an issue. So not for everybody, but for those who use it, it seems to work and work pretty well. Okay, I'll finish this. The tier 3s are just basically the sponges and what have you. Injectables involve the progesterone, medroxyprogesterone acetate, MPA. This is the one that's the trade name Depo-Provera, because it's a Depo shot. Depo-Provera is given intramuscularly. There's now a subcutaneous version of Depo. It's called sub-Q Depo-Provera. And the IM is essentially injected every 3 months, as is the sub-Q. Amenorrhea is very common after 2 injections. The most frequent adverse effect is unpredictable bleeding, and then also weight gain, headache, abdominal pain, decreased sex drive. The big issue with this is that there's a decrease in bone density. So most of the ACOG, that's the American College of Gynecologists, recommend no longer than 2 years for this drug. Also, if you want to return to fertility, it takes 6 to 12 months for your menstrual cycle to come back. So this drug has its caveats. All right. You know what? Just read about tier 3s on the PowerPoints. They're kind of pretty self-explanatory. Sponges, spermicides, what have you. So we got through a good deal today. We will start then on the next chapter, which is endocrine. Next time, we'll do endocrine, and we'll just keep going as far as we can get before. And if you guys can please watch those other ones, and that will do it. Okay? If you have any questions, I will hang out here. And if you want some more apple crisp, please do so. Yeah.
So this is the hypertension room.
Yeah.
It says what is the cell that I thought